Hi guys, now we are going to start venous disorders. In this chapter, we will be discussing anatomy of deep venous system, deep venous thrombosis, anatomy of lower limb venous system, venous pathophysiology, clinical features of venous hypertension, CEAP classification of chronic venous disorders, and after that we will be discussing varicose veins, varicose ulcer or venous ulcer, and syndromes associated with AV malformations, superficial thrombophlebitis, and axillary subclavian vein thrombosis. So let's start. First, see the anatomy of lower limb deep venous system first. So you know there is superficial venous system, there is deep venous system. Obviously, superficial venous system, it is located within superficial tissues. So superficial venous system located within superficial tissues. It is located within superficial tissues, and you know that deep venous system, it is located beneath deep fascia. It is located beneath deep fascia. Deep fascia. Okay. Now see here, there are paired anterior and posterior tibial vein. There are paired peroneal vein. So these paired anterior tibial, posterior tibial, and peroneal vein, it is going to join and it is going to form popliteal vein. So it is going to join and form popliteal vein, and after that, this popliteal vein in thigh, it becomes what? Femoral vein. So what happens? Ultimately, there is formation of what? This femoral vein. Femoral vein. So you can see here the anatomy of deep venous system. In this case, you can notice that this is peroneal vein, this is posterior tibial, and this is anterior tibial. All these three are paired. Clear? So paired anterior tibial, posterior tibial, and peroneal. These are going to join and form what? These are going to join and form popliteal vein, and ultimately this popliteal vein becomes common femoral. So ultimately it becomes femoral vein. Here you can notice that this is long saphenous vein or great saphenous vein. This is the superficial vein, and this great saphenous vein, it is going to join femoral vein at the junction, and you can see this is saphenofemoral junction. You know what is the location of this saphenofemoral junction? It is located 4 centimeter below and lateral to pubic tubercle. So these are important points related to deep venous system. And now we are going to discuss the deep venous thrombosis. You know that there is a triad which should be positive for DVT, and what's the name? It is Virchow's triad. So Virchow's triad, it should be positive for DVT. Yes, it should be positive for deep venous thrombosis, and the components are endothelial injury, stasis, and hypercoagulable state. Endothelial injury, stasis, and hypercoagulable state. It should be positive for DVT. Now see the important risk factors for thrombosis. It is further divided into two categories: inherited and acquired. So there are two categories of risk factors for thrombosis: inherited and acquired. So first, see the inherited factors. Defective inhibition. If there is defective inhibition of coagulation factors, like the patients who are having factor 5 lead-in. What is the problem here? Factor 5 lead-in, it is resistant to inhibition by activated protein C. It is resistant to inhibition by activated protein C. And you have read in gynae as well as in surgery that protein C deficiency, protein S deficiency, again it is going to increase the risk of thrombosis. Antithrombin 3 deficiency. So first group is defective inhibition of coagulation factor. Second is impaired clot lysis. So the patients in whom there is dysfibrinogenemia, or patient is having plasminogen deficiency, or there is tissue plasminogen activator deficiency, or if there is plasminogen activator inhibitor 1 excess. In all these cases, there is impaired clot lysis, and obviously what will happen? Yes, there is increased risk of thrombosis. Next, in medicine, it is asked frequently that there are certain uncertain mechanisms by which there is increased risk of thrombosis in patients who are having homocystinuria and hyperhomocystinemia. These two you have to remember: homocystinuria and hyperhomocystinemia. Right? So these were the inherited factors. Now see the acquired factors. If patient is having lupus anticoagulant, or patient is suffering from some malignancy, there is myocardial infection, there is PNH. What is the full form of PNH? Paroxysmal nocturnal hemoglobinuria. TTP, that is thrombotic thrombocytopenic purpura, or the patients who are having nephrotic syndrome. In all these cases, there is increased risk of thrombosis. Next, these are very important, especially in surgery. What? Pregnancy, physiological states like pregnancy, especially in which period there is increased risk of DVT? Tell me. Pregnancy, especially in postpartum period. In pregnancy, especially in postpartum, especially in the postpartum period. Obesity, again, it's a risk factor, prolonged immobilization, and post-operative state. Post-operative state. So these are the risk factors. Clear? After that, this question was asked many times in exam. What is the most common genetic cause of thrombophilia? What is the most common congenital cause of venous thrombosis? And what is the most common genetic hereditary blood coagulation disorder? And for all these, the answer is same. It is factor 5 lead-in. So for all these, answer is same. This is factor 5 lead-in. This is factor 5 lead-in. And we discussed that what is this? What is the problem with this? Because factor 5 lead-in, it is resistant to inhibition by activated protein C. Now see the surgeries associated with risk of DVT. Surgeries associated with risk of DVT. So see the stratification of surgical procedures and risk of DVT. In which surgeries there is low risk of DVT. Start from top. Neurosurgery, maxillofacial surgery, cardiothoracic surgery. So low risk in neurosurgery, maxillofacial surgery and cardiothoracic surgery. Now come below diaphragm. Below diaphragm there is abdomen, and after abdomen there is pelvis. So what happens? Abdominal and pelvic general surgery, urological surgery and gynecological surgeries. These are having medium risk. So how to remember? In abdomen and pelvis. So you can see here abdominal surgery, inguinal hernia, urological surgery, gynecological surgery. So these are having medium risk. High risk, yes, it is orthopedic surgery, pelvic and lower limb. Pelvic and lower limb orthopedic surgery. So can you see here? High risk in pelvic surgeries. Doesn't matter it's elective or trauma surgery when there is hip replacement. Clear? So hip replacement or there is hemiarthroplasty. So pelvic, elective or trauma surgery, total knee and hip replacement. These are having high risk of DVT. So I'm repeating, it's easy to remember. Start from top. Head and neck means neurosurgery, maxillofacial, cardiothoracic. Low risk, abdomen and pelvis. General surgery, gynecological surgery, urological surgery. These are having medium risk, and come below pelvis, pelvis and lower limb, orthopedic surgery. These are having high risk. So pelvic and lower limb orthopedic surgeries are having high risk. Clear? So this is the stratification of surgical procedures, and these are the risk of DVT. So the patients in whom there is risk of DVT, obviously we go for DVT prophylaxis. There are two types of prophylaxis. One is mechanical and the second is pharmacological. Now see the mechanical. You have seen in surgery ward that after surgery we encourage patient for early ambulation. We tell the patient that go to the bathroom, start walking around the bed. So throughout the day and night you are not supposed to lie down in the bed. So what? Early ambulation, and you know this is the simplest method. Early ambulation, that's the simplest method. That's the simplest method, right? And in AIMS and INICT, this image-based question was asked. This was the image-based question. The question was asked that what is this? Yes, you can see these are pneumatic compression devices or sequential compression devices. These are most commonly used method. So this is pneumatic compression devices, also known as sequential. These are pneumatic or sequential compression devices, and these are most commonly used method. Clear? So why we are using this method, most commonly used method? Why? Because some patients, they cannot be mobilized after surgery. If there is pelvic surgery, orthopedic surgery, or patient is massively obese, patient cannot walk. So in the patients who cannot be mobilized just after surgery, in these patients we are going for what? Pneumatic or sequential compression devices. And whenever we are going to inflate these sequential compression devices with air, what happens? It imitates walking. What happens? It imitates walking. So there is contraction, there is relaxation, and it is going to promote the blood flow. So this is most commonly used method. What are the pharmacological method? The drugs used, either we can use unfractionated heparin, UFH, or we can use low molecular weight heparin. You tell me which one is preferred. So we are preferring low molecular weight heparin. Why? Because here monitoring is not required. So for pharmacological method, you know that low molecular weight heparin, this is preferred. Why this is preferred? Because here monitoring is not required. Monitoring is not required. So I'm telling you the questions here. Monitoring is not required. It is not required. That's why preferred. Preferred is low molecular weight heparin. So question, simplest method of DVT prophylaxis, early ambulation, most commonly used method, pneumatic or sequential compression devices, and preferred pharmacological drug, that is low molecular weight heparin. Now there is a concept of DVT which is very easy to understand. Imagine if this is a vein If the diameter of vein is small, what's the problem? If there is thrombus, thrombus is strongly adhered to the wall. You can see the thrombus. Thrombus is strongly adhered. And if thrombus is strongly adhered, what will happen? There are lesser chances of embolism. So thrombus is strongly adhered. That's why there are lesser chances of embolism. And just imagine if the vein is large. In this case, what's the problem? The thrombus, it's loosely attached. And if thrombus is loosely attached in a larger vein, what will happen? There is high risk of embolism. That's why in larger veins, what happens? There is increased risk of pulmonary embolism in comparison to smaller vein. So important questions I'm going to discuss. First, to tell me, what is the most common site of DVT? Calf vein or soleal vein. So most common site of DVT, that is calf vein. It is calf vein, which is also known as soleal vein. It is calf vein or soleal vein. We discussed that. There are lesser chances of pulmonary embolism if the thrombus is in a smaller vein. So you can see here, most common site of DVT leading to pulmonary embolism. So the diameter should be larger. And what is that vein? Thigh vein. What is the other name? Femoropopliteal vein. So most common site of DVT leading to pulmonary embolism. This is thigh vein. This is thigh vein. And obviously, what's the name? Thigh vein. So this is femoropopliteal vein. So it is thigh vein. Obviously, this is femoropopliteal vein. So it is thigh vein. Obviously, this is femoropopliteal vein. Right? You know that if there is superficial thrombophlebitis, hardly there is any embolism. Why? Because thrombus is strongly adhered to the wall. So this is one concept. Clear? Imagine any patient in whom there is thrombosis in the vein. What will happen? There is pain, there is tenderness, and what will happen? There is impaired venous drainage, and because of impaired venous drainage, what will happen? There is swelling. So the most common presentation, or I should say, what is the most common symptom of DVT? That is pain and swelling in the calf region. So it is pain, most common symptom or presentation. This is pain and swelling in calf region. Clear? So there is pain and swelling in calf region. Now you tell me, what is the most common sign? Whenever you're going to press the calf, there is calf tenderness. So the most common sign, that's calf tenderness. It's calf tenderness. Clear? Calf tenderness. This question was asked long back in NEET PG, that bilateral DVT is common or rare. Yes, the risk factors are there. That's why you can't believe that bilateral DVT is seen in 30% cases. So it's common or rare? It's common. Bilateral DVT, it is seen in 30% cases. It's common. So bilateral DVT seen in 30% cases. So you know that it's common, right? What is the problem? We discussed that whenever there is deep venous thrombosis, it can cause pulmonary embolism. And because of pulmonary embolism, if the embolus is large, what can happen? It can cause sudden death also. If there is a large embolus, yes, it can cause sudden death. Otherwise, what are the other manifestation? If patient is having pulmonary embolism, see the manifestations. Yes, patient can have pleuritic chest pain, there is hemoptysis, there is dyspnea. Some patients after DVT, they started having low grade fever. Why there is low grade fever? Low grade fever, this is an indirect evidence, or it's typically seen in recurrent pulmonary emboli. So low grade fever typically seen in the patients who are having recurrent pulmonary emboli. The patients having recurrent, so patients having recurrent pulmonary emboli. Clear? The patients who are having recurrent pulmonary emboli. Okay. Next, what are the signs? We already discussed there is calf tenderness. So most common sign, that's calf tenderness. You press the calf, there is pain. So that's calf tenderness, right? Another problem, since the deep venous system is obstructed because of thrombosis, what's the problem? There is impaired venous drainage, and if there is impaired venous drainage, patient will be having edema. What kind of edema? Initially, patients are having pitting edema, and later it becomes non-pitting. So what kind of edema? Initially, edema is pitting. So initially, patients are having pitting edema followed by non-pitting, edema. And if patient is having thrombosis, you are going to perform the palpation, deep palpation. There is tenderness along the course of vein. So what you're going to notice that there is tenderness along the course of vein. Clear? So there is tenderness along the course of vein. There is tenderness along the course of vein. These are the signs. There are other important signs you can see here. Suppose this is the foot. We are going to perform passive dorsiflexion of foot. There is increased resistance. And if there is increased resistance, you can see there is increased resistance to passive dorsiflexion of foot. What's the name of this sign? Homan sign. So name of this sign, this is known as Homan sign. Name, this is known as Homan sign. Clear? So increase resistance to passive dorsiflexion of foot. After that, if you're going to apply pressure on the calf region causes pain. What is the name of this sign? This is known as Moses sign, also known as Bancroft sign. So application of pressure over calf leads to pain. What's the name? Moses or Bancroft sign. You have to remember. This is known as Moses. You can see here Moses or Bancroft sign. Clear? So it is known as Moses or Bancroft sign. Whenever you are going to squeeze the calf, so pain on squeezing of the calf, that is known as Pratt sign. So here you can notice that we are performing squeezing of calf. So there is pain on squeezing, and what's the name? Pratt sign. Name, Pratt sign. Pratt sign. Let me tell you, Homan sign, it's non-specific. So there is increased resistance on passive dorsiflexion of foot. Name, Homan sign, it is non-specific. Now see the color of lower limb. Yes, you can see here, this patient is having edema. You can see here, the right limb, edema. This patient is having edema. Simultaneously, the patient is having bluish discoloration. So there are two terms. One is phlegmasia alba dolens. Phlegmasia alba dolens means painful, alba means white leg. And cerulean dolens, that is painful blue leg. So you can see the first one, that is phlegmasia alba dolens. So this is painful white leg. And you can see the second one, this is phlegmasia cerulean dolens. So here it's blue. Next, in both, what are the similarities? In both patients, there is DVT. Important point. So both of these patients are having DVT. Both of these patients are having deep venous thrombosis. Okay. You have to tell me, one patient is having patent collaterals and one patient is having obstructed collaterals. Remember, whenever there is deep venous thrombosis and patent collaterals are there, so these patent collaterals are going to drain the deoxygenated blood. But if collaterals are also obstructed, so both deep as well as superficial system means collaterals are going to contain what? Deoxygenated blood. So if collaterals are also obstructed, what will happen? There is collection of deoxygenated blood, and that's why it is bluish. So in first one, phlegmasia alba dolens, there is DVT with patent collaterals. So there is DVT with patent collaterals. Patient is having DVT with patent collaterals, right? But in the second one, patient is having DVT with obstructed collaterals. Clear? So it is DVT. Patient is having DVT with obstructed collaterals. Obstructed collaterals. Clear? So this is phlegmasia alba dolens and phlegmasia cerulean dolens. In majority of cases, these questions are asked in the form of image-based question, right? Next, this is very, very important. Modified Wells criteria. Wells criteria for predicting DVT. Okay. Now see the variables and the score. We discussed that which surgeries are having highest risk. Highest risk, obviously, orthopedic surgery, pelvic and lower limb. Pelvic means hip replacement, knee replacement, and hemiarthroplasty. So pelvic and lower limb surgeries. So see here, lower limb trauma or lower limb surgery or immobilization is there in the plaster cast. Yes, the score is 1. Second, patient is bedridden for more than 3 days. You have to remember the duration, more than 3 days, or surgery is done in the last 4 weeks. Or if there is tenderness, we discussed that if a patient is having DVT, you perform the deep palpation and there is tenderness along the course of deep vein. So if there is tenderness along line of femoral and popliteal vein, or the entire limb is swollen. Why entire limb is swollen? Because of impaired venous drainage. So obviously patient is having edema. Whenever patient will be having edema, if you are going to measure the calf is more than 3 centimeter larger in circumference than the other side. And exactly where we are going to measure it, 10 centimeter below the tibial tuberosity. So it is measured exactly 10 centimeter below tibial tuberosity. We discussed what kind of edema. Initially there is pitting, later there is non-pitting edema. So what? Pitting edema. If there are dilated collaterals, what collaterals? Superficial veins. Remember, these are not varicose veins. These are dilated collaterals. Patient already had DVT previously. So previous DVT, patient is having malignancy. It includes the treatment up to 6 months ago. There is IV drug abuse or there is alternative diagnosis more likely than DVT. Now what you have to remember, see, For most of the parameters, the score is 1. What you have to remember that for intravenous IV drug abuse, the score is 3. Clear? And if there is alternative diagnosis, the score is -2. So for rest of the parameters, score is 1. For IV drug abuse, it is 3. For alternative diagnosis, it is -2. Right? So we have to calculate the score. And if there is low probability, how much is the probability of DVT? 5% only. So what is the score? It's -2 to 0. So if score is -2 to 0, there is low probability, means only 5% chances of DVT. This is modified Wells criteria for predicting DVT. Moderate probability, how many chances are there? How much chances are there? 17%. And here, how much is the score? Score is 1 or 2. So if score is 1 or 2, moderate probability, and whenever score is more than 2, there is high probability. And can you see here, how much is the percentage? 17 to 53. So this is modified Wells criteria, one of the frequently asked question nowadays. Now, what is the investigation of choice for diagnosis of DVT? Let me tell you, investigation of choice for DVT as well as varicose vein, it is same, that is duplex scan. So it is duplex, in which we are going to include both ultrasound as well as Doppler. So we are going to assess the flow as well as we have to see the anatomy. So what is the investigation of choice for diagnosis? It is duplex. So by this duplex, we are supposed to assess the flow. We are going to assess the flow and you are going to assess the anatomy. Anatomy. Obviously, if the vein is obstructed, what will happen? There is impaired flow. So what happens? This is the vein and here is the thrombus. So if vein is there, there is the thrombus. What happens? If at the site of thrombosis, you are going to compress the vein, it is difficult for you to compress the vein with the probe. So at the site of thrombosis, it is difficult for you to compress the vein. Clear? So investigation of choice for diagnosis of DVT, that is duplex, which includes both Doppler as well as ultrasound. So we are going to assess flow and anatomy. Now, the management. Let me tell you the basic principle of management of venous thrombosis anywhere in the body. Doesn't matter if patient is having deep venous thrombosis, mesenteric venous thrombosis, hepatic venous thrombosis, or axillary subclavian vein thrombosis. In all these kinds of venous thrombosis, first stop the thrombotic process and then start the anticoagulants. So it doesn't matter whether patient is having DVT, mesenteric venous thrombosis, hepatic vein thrombosis, axillary subclavian vein thrombosis, first stop the thrombotic process and then start the anticoagulants. Can you tell me what's the drug of choice? Here we are going to start IV heparin. And for how many days it's given? 5 days. So drug of choice, it is IV heparin. Drug of choice, this is IV heparin. And for how many days IV heparin is given? It is given for 5 days. 5 days. We have to start warfarin also, but you know that it is going to start acting after 72 hours. That's why monitoring should be required or dose adjustment is required 3rd day onwards. So here, warfarin, again it should be started, but it acts after 72 hours. That's why from 3rd day onwards, from 3rd day onwards, dose monitoring is required. From 3rd day onwards, we have to go for dose monitoring. Dose monitoring is required. Dose monitoring is required. Next, what is the duration of treatment? If the patient is having first episode, minimum treatment time of anticoagulation should be 3 months. If there is first episode, minimum treatment time of anticoagulation should be 3 months. Minimum treatment time of anticoagulation. And if patient is having recurrent DVT, here in these cases we go for lifelong treatment. So lifelong anticoagulant should be given. It's lifelong. We discussed that in the management we are giving heparin as well as warfarin. So how we are going to monitor? For heparin, monitoring is done on the basis of APTT. And when you use heparin, what should be the reference dose? 1.5 to 2.5. So heparin, here it should be monitored with APTT. APTT, and the reference range, it should be 1.5 to 2.5. Right? And warfarin, you know that for warfarin, what is the investigation which is done for monitoring? It's INR. What's the full form of INR? That is international normalized ratio. And here the reference range should be 2 to 3. So here the reference range should be 2 to 3. Right? So for heparin, it is APTT, reference range 1.5 to 2.5. Warfarin, it is INR, it is 2 to 3. And guys, you can't believe, from these two lines, total 4 questions are asked. So they asked investigation, they asked the reference range. There is a surgical treatment of DVT. Sometimes examiners are asking the name. What's the name of the operation? It is PAMA operation. What's the name of the operation? Name of operation, it is PAMA operation. So name, it is PAMA operation, and this is the surgical treatment of DVT. So PAMA operation, that's the surgical treatment. Is the surgical treatment of DVT, that is the PAMA operation. PAMA operation. So this is DVT management. Now see the superficial veins. The most important veins are obviously great saphenous vein and short saphenous vein. You know, great saphenous vein, it is also known as long saphenous vein. Can you tell me why it is known as long saphenous vein? Because it is very, very long. And you know that long saphenous vein is the longest vein of the body. So why God gave us this long saphenous vein? Because it's very, very long. God was knowing that this person will not have any kind of dietary restriction. That's why there will be coronary artery disease. So in future, if CABG has to be done, what? These veins will be used. So you know that most commonly used graft in CABG, that is coronary artery bypass grafting, it is long saphenous vein, also known as great saphenous vein. But most preferred graft, that is LIMA. What is LIMA? Left internal mammary artery. So let's see the questions related to great saphenous vein. First, what is the location of saphenofemoral junction? Obviously, it is 4 centimeter below. Location 4 centimeter below and lateral to pubic tubercle. 4 centimeter below and lateral to pubic tubercle. We discussed that this is the longest vein in the body, and this is most frequently vein affected by superficial incompetence. Most frequently affected vein. So this is most frequently affected vein by superficial incompetence. Superficial incompetence. Incompetence. Right? You know that this vein, it is in close relation with which nerve? Saphenous nerve, especially below the knee. So whenever we are going for harvesting of this vein, or whenever we are going for stripping of this vein, especially in varicose vein, what happens? The stripping should not be done below the knee joint because it is closely related to saphenous nerve below the knee joint. So closely associated with saphenous nerve. Closely associated with saphenous nerve below the knee. Saphenous nerve below the knee. Below the knee. That's why whenever we are going for stripping of varicose vein, it should not be done below the knee. Otherwise, there is increased risk of injury of this saphenous nerve. And we discussed that this is most commonly used graft in CABG. Right? What is most preferred graft in CABG? LIMA, that is left internal mammary artery. So the questions which examiners are asking, it is related to what? Surgery or stripping of varicose vein, and second, harvesting. So during harvesting of long saphenous vein, there is injury of which nerve? Saphenous nerve. During stripping of long saphenous vein or great saphenous vein, there is injury of saphenous nerve. So you can see this vein, it originates in dorsum of foot from dorsal venous arch, you can see here, and then passes anterior to this medial malleolus, and after that ultimately it is going to drain into femoral vein. And what is this junction? You can see this junction is saphenofemoral junction. So ultimately it is going to drain into femoral vein at this saphenofemoral junction. So name, this is great saphenous vein. What is the other name? This is also known as long saphenous vein. Now see the short saphenous vein. This short saphenous vein, it arises from lateral end of venous arch, and after that it goes posteriorly. So this vein goes posteriorly. What is the location? It is located posteriorly. What is the location of long saphenous vein? If you have seen, it is anteromedially. It drains into, ultimately it drains into SPJ. Long saphenous vein was draining into saphenofemoral junction, which was located 4 cm below and lateral to pubic tubercle. But this saphenopopliteal junction, let me tell you guys, this is highly variable. That's why whenever we are planning the surgery of this saphenopopliteal junction or short saphenous vein, before surgery, the location of saphenopopliteal junction, it should be marked by radiological investigations. So what? The location is variable. Since location of this saphenopopliteal junction, it's variable. Before surgery, this location should be marked by a permanent marker. Next, it is closely related to which nerve? It is closely related to obviously sural nerve along its whole course. Sural nerve along its whole course. That's why this question is also asked, that whenever you are going to perform stripping of short saphenous vein, which nerve is most commonly injured? Obviously sural nerve. There is one question which is expected, that there is cranial extension of short saphenous vein, and what is the name? This is known as Giacomini vein. Cranial extension of short saphenous, this is known as Giacomini vein. Giacomini vein. Clear? So this Giacomini vein, actually it is going to connect with great saphenous vein. So it's the cranial extension of short saphenous, it is going to connect. So it connects with great saphenous. connects with great saphenous vein, and suppose during stripping this is missed, what happens? It's the cause of recurrence following surgery or after surgery. So this is the Giacometti vein which is actually missed during stripping, and it's the cause of recurrence following surgery. So it's the cause of recurrence following surgery. Clear? So this Giacometti vein is the cause of recurrence following the surgery. Following surgery is the cranial extension, and obviously it's connected with great saphenous vein. So you can see here the course, you can see that it arises from lateral end of venous arch, and after that you can notice that it goes posteriorly, and where exactly it is going to drain? Saphenopopliteal junction, which is highly variable in the location, and the cranial extension of this is known as Giacometti vein. It connects with great saphenous vein, and we discussed is the cause of recurrence following surgery. Now see the perforators. Perforators are going to connect superficial to deep venous system. So ultimately what happens? The venous drainage goes in superficial system and deep venous system. Via perforators, the blood from superficial system goes to the deep, right? How many number of perforating veins are there in the lower limb? You can't believe. The number of perforating veins in the lower limb, it's around 100 to 150. So number of perforating veins in the lower limb, that's around 100 to 150. And you can see what are the names of perforators. So examiners are asking the named perforators. So you can see here, yes, just below medial malleolus, there is May or Custer perforator. Can you see? May or Custer, that is just below medial malleolus. After that, you can see over the medial calf, that is known as cocket perforators of posterior arch line. So cocket perforators of posterior arch line location over the medial calf. Then below the knee, there are boyd perforators. Above the knee, especially in the distal thigh, dot perforators, and in proximal thigh, there are Hunterian perforators. So how to remember? May CBD hunters. Mnemonic is it's May CBD hunters. You can see here May CBD hunters. So May, that is May or Custer, below medial malleolus. Over the medial calf, that is C, that is cocket perforators. After that, below the knee, boyds. Above the knee, where exactly? In the distal thigh, there is dot perforators, and obviously in the proximal thigh, Hunterian perforators. So May CBD hunters, these are the named perforators of the lower limb. Now see the venous pathophysiology. You know that calf muscle, it is also going to work like a pump or like a heart. So what happens? Whenever there is contraction of calf muscle, this is known as systole, and whenever there is dilatation, that is known as diastole. So in this case, you can see here that there are superficial vein and deep veins, and these superficial and deep are connected by perforators. What is the direction of blood flow? Obviously, you know that the direction of blood flow is from periphery towards heart. So the direction of blood flow is from periphery towards heart in both deep venous system as well as in the superficial venous system. Ultimately, what will happen? The blood from periphery goes to the heart. Next, blood from superficial system, it goes to deep venous system via perforators. And you can see that valves are there in superficial vein, in deep vein as well as in perforator. Clear? So whenever there is systole, blood is pushed towards heart. Whenever there is diastole, what happens? Blood comes from superficial to deep. If patient is having incompetent valves, so if there are incompetent valves during systole, blood will be going towards heart, but what will happen? The blood is going from deep to superficial, and during diastole, blood will come back. So what will happen? You can see during systole, blood is going towards heart. You can see blood is going towards heart, but during systole, blood is also going from deep to superficial, which is abnormal. And during diastole, means during relaxation, blood comes back. So can you see here? There is, what happens? You can see there is regurgitation of blood. So here, varicose vein is just like a type of regurgitant lesion, like tricuspid regurgitation or pulmonary regurgitation. So if there is regurgitant lesion of heart, since most of the blood comes back, so what will happen? There is increased end diastolic volume. And if there is increased end diastolic volume, so what will happen? Mostly both superficial as well as deep venous system will be distended with blood. So because of increased end diastolic volume, both superficial and deep venous system, it is distended with blood. Since it is distended with blood, what will happen? You can see dilated veins. And because of that, what will happen? There is increased pressure in the vein. And because of this increased pressure, this phenomena is known as what? Chronic ambulatory venous hypertension. So most of the complication of varicose vein are because of what? Chronic ambulatory venous hypertension. So in this image, you can notice that what this is the normal vein. You can see here, and the valve is open, so you can see the direction of blood flow. Whenever valve is closed, you can see the blood is not coming back, so it is going to prevent the reversal of blood flow. But what happens if there is regurgitant lesion? If there is incompetent valve, what will happen? Yes, there is regurgitation of blood. So what will happen? Ultimately, blood will come back, and there is increased in diastolic volume. So what will happen? Most of the times, superficial as well as deep venous system will be distended with blood, leading to chronic ambulatory venous hypertension. According to Bailey 28th edition, there are certain definitions which you have to remember. First, what is the definition of varicose vein? It is dilated, elongated, tortuous vein. So where exactly? Subcutaneous dilated veins. What should be the diameter? Diameter more than equal to 3 mm. So diameter more than equal to 3 mm. After that, there are telangiectasia. How to remember telangiectasia? Mnemonic is TSH. It is also known as TSH. What is TSH? T means thread vein, S means spider vein, H means hyphen vein. So thread vein, spider vein, hyphen vein. These are tiny intradermal venules. And what's the diameter? Less than 1 mm. Tiny intradermal venules of diameter less than 1 mm. And reticular veins, these are bluish subdermal vein, and the diameter is in between telangiectasia means thread vein and varicose vein. So obviously it is 1 to 2.9 mm. It means it is 1 to less than 3 mm. So remember these diameters. Varicose vein more than equal to 3 mm. Thread veins, spider veins or hyphen veins, diameter is less than 1 mm. And what reticular veins? 1 to 2.9 mm. What is Safina varix? These patients are having usually after surgery. What happens if you are not going for flush ligation? There is painless groin swelling, and that becomes more prominent on standing. So that is known as Safina varix. This is painless groin swelling. Painless groin swelling. In which cases it is seen? Yes, whenever we are going for Trendelenburg operation, but if you're not going for flush ligation means at just the origin you are going to ligate long saphenous vein. If you leave the stump, what will happen? That stump becomes swollen, especially in standing position, known as Safina varix. There is a new term that is corona phlebectatica. That is corona phlebectatica. That is also known as malleolar flare. It looks like fan shaped. So there is fan shaped pattern of telangiectasia that is known as corona phlebectatica. And the patients who are having venous hypertension or varicosity, what kind of edema these patients are having? These patients are having pitting edema. So what kind of edema is there? Pitting edema. And we discussed that in patients of DVT, initially there is pitting edema followed by non-pitting edema. There is eczema. These patients are having erythematous dermatitis, that is eczema. There is pigmentation. What is the color? Brownish discoloration is there. That is deposition of hemosiderin, and that's why it is also known as hemosiderosis. So brownish discoloration of skin because of deposition of hemosiderin. This is hemosiderosis, and let me tell you guys, it is permanent. Where exactly you're going to find this kind of discoloration? Around ankle. So pigmentation, hemosiderosis, it is permanent, and where exactly we are going to find it? Yes, you have seen in patients, exactly it is located around ankle. So what's the location? It is located around ankle joint. The most important is this, that is lipodermatosclerosis. Dermato. So here there is involvement of skin and subcutaneous tissue. What's the problem? There is chronic inflammation and fibrosis involving skin and subcutaneous tissue. Skin and subcutaneous tissue. Clear? And whenever you are going to perform the examination palpation, what happens? It results in tight, contracted, woody leg. There is tight, contracted, woody leg, and it can also cause what? Contracture of Achilles tendon. It can lead to contracture of Achilles tendon. There is another term, what? Atrophy blanche. Atrophy means obviously atrophic. Blanche means what? White skin. So here, these patients are having localized area of atrophic white skin. Atrophy blanche. Yes, atrophic white skin. Now, what happens? This atrophy blanche, actually it is surrounded by telangiectasia and pigmentation. Let me tell you, lipodermatosclerosis as well as atrophy blanche, both of these are signs of severe chronic venous disease. Both of these, lipodermatosclerosis as well as atrophy blanche, both of these are signs of severe chronic venous disease. These are signs of severe chronic venous disease. Clear? Next, venous ulcer, and you know that whenever there is full thickness skin loss around ankle, there is venous ulcer. So it is because of full thickness skin loss. So this is because of full thickness. Clear? It is because of full thickness skin loss, right? So that's the venous ulcer. Nowadays, one topic which is very important and asked frequently in most of the exams, that is CEAP classification. CEAP classification of chronic venous disorders. You can see the full form. C. C means clinical manifestations. E. Etiological classification. A. Anatomical distribution. And P. Pathophysiological dysfunction. Clear? So this clinical manifestation, it is graded between 0 to 6. Now if it is A means there is asymptomatic presentation. A means patient is having asymptomatic presentation, and S, these patients are having symptomatic presentation. Asymptomatic presentation, symptomatic presentation. Clear? So one by one we are going to discuss in detail. Mostly examiners are asking what? This C. So you can see here C0. It is C0 to C6. So C0, there is no visible or palpable sign. That is C0. If it is C1, there is telangiectasia or reticular vein. If it is C2, here you have to remember that varicose vein starts from C2. After that, complication starts. So in C3, patient is having edema. In C4, there are skin changes. In C5, there is healed wound. And in C6, there is open wound. Clear? So C2, actually varicosity starts from C2, varicose vein, C2, C3 is edema, C4 skin changes, C5 healed wound, and C6 open wound. Clear? So let's discuss in detail and let's discuss the questions. C0 we discussed, no signs of venous disease. If telangiectasia or reticular veins are there, it is C1. Varicose vein, that is C2. Edema, C3. C4, this you have to remember because this is very, very important. C4A, there is pigmentation or eczema. C4B, lipodermatosclerosis or atrophy blanche. We discussed both of these are signs of chronic venous disease. And C4C, 4C, that is corona phlebistatica. Corona phlebistatica. C5, it's easy to remember if there is healed wound, and C6, that is active venous ulcer or active wound. Now guys, let me tell you how to remember. C0 you already know, 0 means no signs. C6 means ultimately there is active ulcer. If you remember C6, active ulcer, healed ulcer, C5. So nowadays mainly questions are asked in between C1 to C4. And how to remember, can you see the mnemonic? TV of pig lip corona. It is TV of pig lip corona. So TV of pig lip corona. T, telangiectasia, it is 1. V, varicose vein, 2. O, edema, 3. Pig, pigmentation, 4A. So pigmentation or eczema, 4A. Lip, lipodermatosclerosis, 4B or atrophy blanche. And corona, corona phlebistatica, that is 4C. So guys, you have to remember this is a potential question. What? TV of pig lip corona. T, telangiectasia, 1. V, varicose vein, 2. O, edema, 3. Pig pigmentation or eczema, that is 4A. Lipodermatosclerosis or atrophy blanche, 4B. Corona phlebistatica, that is 4C. You know healed wound, it is C5. Active ulcer or active wound, that is C6. Now see the etiological classification also starts with E. If it's congenital, we have to add C. If it's primary, we have to add P. If it's secondary, we have to S. And no venous causes identified, we are going to add N. Similarly, you can see anatomical classification starts with A. S, involvement of superficial vein. P, involvement of perforator veins. D, involvement of deep veins. If no venous location is identified, it is AN. And for pathophysiological dysfunction, we are going to use P. If it's R, R means reflux, O means there is obstruction, RO means both reflux and obstruction, and if it's N, there is no venous pathophysiology identifiable. Mostly examiners are asking C, clinical classification, especially C1 to C4. So now we are going to discuss varicose vein. We discussed the definition: dilated, elongated, tortuous vein. Remember the diameter, how much? More than equal to 3 mm. How much? Diameter more than equal to 3 mm. And it is more common in males or females? Guys, it is more common in females. One of the risk factors is prolonged standing. And let me tell you, the prevalence of varicose vein, it increases with age. So prevalence increases with age. It is more common in long saphenous vein or short saphenous vein. I hope you have seen the cases. Obviously, long saphenous vein in 60% cases. So long saphenous vein, it is involved in 60% cases. Short saphenous vein involved in 20% cases only. Now see the diameters, spider veins. We discussed the other names, thread veins, spider veins or hyphen veins. Mnemonic was TSH. Thread veins, spider veins or hyphen veins, diameter less than 1 mm. Second was reticular veins. It is 1 to less than 3 mm means 1 to 2.9 mm. And third, varicose vein, obviously the diameter is more than equal to 3 mm. Now you can see the classification on the basis of involved vein. Imagine whenever there is involvement of this medial aspect or inner aspect of thigh, if the varicose vein is located along inner aspect of thigh and anteromedial aspect of leg, you can see here, involvement of inner aspect of thigh or anteromedial aspect of leg, it means which vein is involved here? Involvement of long saphenous vein or great saphenous vein. And whenever there is presence of varicose vein over posterolateral aspect, you can see here, posterolateral aspect. So here there is involvement of what? Short saphenous vein. So this is the classification on the basis of location. So there is classification based on the cause, primary varicose vein and secondary varicose vein. Here well-defined cause is not there. We say that it is because of congenital predisposition with occupational reinforcement. First, can you tell me what is the meaning of congenital predisposition? Congenital predisposition means already these patients are having lesser number of valve, means decreased valve, or patients are having defective valves. So congenital predisposition means patients are having decreased number of valves. What? Decreased valves. So decreased number of valves, or patients are having defective valves. Clear? Defective valves, right? So that is congenital predisposition. Next, can you tell me occupational reinforcement? Occupational reinforcement means any patient who is already having defective valves, decreased number of valves, and in that patient if there is prolonged standing, occupations in which there is prolonged standing, can you tell me? Yes. Which occupations? Surgeons, teachers, especially school teachers? No, it's PGME teachers, NEET PG teachers who are going to take classes from 9 a.m. to 9 p.m., 12 hours, 10 hours long classes. Clear? So in these people there is high risk. So what happens? Prolonged standing, like surgeons, teachers, traffic policemen, bus conductors. So these are the occupations in which there is high risk. Next, secondary varicose vein. So why it is known as secondary? Because it occurs secondary to obstruction or secondary to compression. So secondary varicose vein means it is secondary to what? It occurs secondary to obstruction, or it occurs secondary to compression. Clear? So secondary to obstruction or secondary to compression. Can you tell me one of the most common cause of venous obstruction and compression? What? DVT. So the most common cause of secondary varicose vein, it is DVT. It can occur because of trauma, AV fistula, or sometimes there is deep venous compression. In which cases? In pelvic mass, pelvic tumor, and pregnancy. Remember, in pregnancy, usually you are going to notice that patient is having varicosity in one limb only. Why? Because gravid uterus is going to take turn, and on that side only it is going to compress the deep veins. And what is the good thing? After delivery, this varicose vein or varicosity disappears. So these are the types of varicose vein on the basis of cause, primary and secondary. Now see the clinical features. If you want to know the clinical features, ask the ladies who are housewives. Yes, what is the problem, especially in your family? They are going to tell you that what happens since they are busy most of the day and night working in the kitchen here and there. And they are going to tell you, especially in the evening hours, there is aching pain, heaviness, throbbing or burning or bursting pain, especially where? Exactly around the calf. So what happens? Aching, heaviness, throbbing or burning or bursting pain over the affected areas. And this obviously increases on prolonged standing. And you are going to ask them, obviously they are going to tell you that especially it is more marked in evening hours. So on prolonged standing, it increases. And obviously it is relieved by limb elevation or by use of compression hosiery. So relieved by limb elevation, or by use of compression stockings or compression hosiery. If you are going to use compression stockings or compression hosiery. Yes, these are the symptoms. What else happens? In these patients, we discussed that there is chronic ambulatory venous hypertension. And because of this chronic ambulatory venous hypertension, complication occurs. So what's the cause of complication? The patients are having chronic ambulatory venous hypertension. So it is because of chronic ambulatory, clear? So it is because of chronic ambulatory venous hypertension. So this is chronic ambulatory venous hypertension which is responsible for complications. Can you see in this patient what kind of discoloration is there around the ankle? Can you notice? Yes, what kind of discoloration? You are going to notice that there is brownish discoloration around the ankle. It is because of deposition of hemosiderin. So this is also known as hyperpigmentation, also known as hemosiderosis. What's the name? Hyperpigmentation, discoloration around ankle, brownish discoloration because of deposition of hemosiderin. That's why what's the name? It is also known as hemosiderosis. Another thing is lipodermatosclerosis eczema, and ultimately you can see the patient can develop what? Varicose ulcer or venous ulcer. And what is the typical location? It is located in Gator's area, that is just above medial malleolus. So this is what? Venous ulcer. These are the complications. Now, what are the tests performed in varicose vein? First, Morrissey's test. This is cough impulse test. What is Morrissey's test? This is cough. So this is cough impulse test. So Morrissey's test, this is cough impulse test. Cough impulse test. After that, Schwartz test. What's the problem? Imagine this is the vein which is dilated. Yes, if it is distended and dilated, what will happen? Yes, the space between the valves is more. So obviously it's not going to close properly. Whenever you are going to tap the vein below, if you start tapping the vein below, you can feel the impulse above. So this is known as Schwartz test. So in Schwartz test, tapping the lower part of varicosity. So what we do? Tapping the lower part of varicosity. Here we are tapping the lower part of varicosity and feeling the impulse above. So we are going to feel the impulse, feeling impulse above. So tapping lower part of varicosity and feeling the impulse above. That is Schwartz test. Why? Because the vein is distended. That's why you can feel the impulse. Next, Perthes test. For DVT, we are going for Perthes test. So what is done in Perthes test? You can see here, elastic compression bandage is applied around the lower limb and patient is asked to do the work or exercise. Whenever patient is doing work or exercise, if patient is having crampy pain, why there is crampy pain? Because of this elastic compression, what happens? Superficial vein is already obstructed and deep vein, if it's obstructed because of DVT, that's why the patient will be having what? Crampy pain. So you can notice that if the patient is having crampy pain after application of this elastic bandage, it means patient is having DVT. So after work or exercise, if the patient is having crampy pain, patients who are having crampy pain after work or exercise, it is because of DVT. What we have applied here, we have applied elastic bandage in the lower limb. At the place of elastic bandage, if you are just going to apply the tourniquet and then do the test in the same manner, this is known as modified Perthes. So you can see modified Perthes. Again, it is for DVT. In this case, you can notice that tourniquet is being applied. And in this case, patient is allowed to do the work or exercise. And after that, if again patient is having what? Crampy pain, it is suggestive of DVT. Clear? Why? Because by this tourniquet, you have occluded saphenofemoral junction. Yes, because it is applied at saphenofemoral junction. So drainage from superficial system has been blocked, and if drainage from venous system, deep venous system, if it's already blocked, what will happen? Crampy pain. So modified Perthes test, at the place of elastic bandage, we are applying the tourniquet. Here also, after work or exercise, patient is having crampy pain and it means patient is having DVT. So this is Perthes and modified Perthes test. Next is Fagan's test. If you're going for deep palpation, there is crescentic defect in fascia. Imagine this is the vein. This kind of defect is there. At the site of incompetent perforator, what happens? At the site of incompetent perforator, what happens? There is crescentic defect in fascia on deep palpation. So Fagan's test, there is crescentic defect in fascia. These patients are having crescentic defect in fascia. Crescentic defect in fascia on deep palpation. Clear? On deep palpation. Where exactly? Where exactly? At the site of incompetent perforators. So at the site of incompetent perforators, there are crescentic defect in fascia. So where exactly? At the site of incompetent perforators. At the site of incompetent perforators, there is crescentic defect in fascia. That is Fagan's test. Most important is this Brody-Trendelenburg test. In Brody-Trendelenburg test, there are two components, component 1, component 2. First see, component 1. Here, we ask the patient to lie supine, we elevate the lower limb and we perform the milking. Milking means emptying of the vein. After performing the milking or emptying of the vein, what? You are going to occlude saphenofemoral junction, which is located 4 cm below and lateral to pubic tubercle with the thumb, and ask the patient to stand. So you apply it, clear? And we ask the patient to stand. Here we apply this kind of pressure from the thumb and we ask the patient to stand. When patient is going to stand, what happens? So after releasing the pressure, whenever we are going to release the pressure, if there is rapid filling by a column of blood from above, it means what is incompetent? This junction is incompetent. Clear? So on releasing the pressure, if there is rapid filling, varices fill quickly by a column of blood from above, it means saphenofemoral junction is incompetent. So component 1, in which if there is rapid filling by column of blood from above, it is suggestive of incompetent saphenofemoral junction. Incompetent saphenofemoral junction. This is component 1. After that, see the component 2. In component 2 also, there are many similarities. We ask the patient to lie. We are going to elevate the limb and perform the milking. So you can see here, milking is done. After milking, we are going to apply the pressure where? At this saphenofemoral junction, and ask the patient to stand. Now don't release the pressure. And if you are not releasing the pressure, and now there is slow filling from below. So varices are going to fill gradually from below. It means what happens? There is incompetent perforator. So see the diagrammatic representation. It is something like this. It is something like this. You can see here. It's something like this. Clear? You can see, right? What happens? This is saphenofemoral junction. These are the perforators. Whenever you're going to occlude this, yes, and release the pressure. If you release the pressure, and what happens? There is rapid filling by the column of blood from above. It means this junction is on incompetent, component 1. And if you are going to apply the pressure, but if there is gradual filling from below, it means there is incompetent perforator, component 2. So this is Brody-Trendelenburg test. So I'm repeating, apply pressure at saphenofemoral junction. Patient should be in the standing position, release the pressure. Varices fill quickly by column of blood from above, suggestive of saphenofemoral junction incompetence. So saphenofemoral junction incompetence. Guys, this question was asked in exam. And apply the pressure, ask the patient to stand but don't release the pressure. Now varices fill gradually here. There is perforator incompetence. So these patients are having perforator incompetence. So there are incompetent perforators. So there is perforator incompetence. That is Brody-Trendelenburg test, component 1, component 2. Now see the investigation of choice for diagnosis of varicose vein. Just like DVT, it is same, duplex. So just like DVT, it is same, duplex, right? What we are going to assess by this duplex scan? Duplex scan, it is going to assess what? SFJ, saphenofemoral junction. You know, location is fixed. So we are going to assess whether this is competent or incompetent. So saphenofemoral junction, it is competent or it is incompetent. Competent or incompetent. Second, location as well as status of saphenopopliteal junction, because you know that the location of saphenopopliteal junction, that is variable. So first, location and status, again it is competent and incompetent. After that, perforators, what? Number and location of incompetent perforators. So perforators, what you have to look for? Number and location. So it's the number and location of incompetent perforators. And another thing which you have to look for, DVT, whether it's present or absent. DVT is present or absent because you know that if patient is having DVT, it's an absolute contraindication for stripping. So presence of DVT, you know, it's absolute contraindication. This is absolute contraindication for stripping. Clear? So by duplex scan, we are going to assess all these informations. What's the management? Guys, nowadays, the gold standard treatment, that is endothermal ablation, which includes endovenous laser ablation and radio frequency ablation. Why it's gold standard? Because it can be performed on daycare basis and there are lesser risk of complications. This is the latest question, gold standard treatment, endothermal ablation. Why this is gold standard nowadays? Because it can be performed on daycare basis. There are lesser complications. And what endothermal ablation techniques we are using? We are using EVLA, that is endovenous laser ablation, and we are using radio frequency ablation. So it is EVLA, endovenous laser ablation, and RFA, that is radio frequency ablation. In some patient, we advise use of compression hosiery. So this use of compression hosiery, it relies on graduated external pressure. Why? To improve deep venous return and to reduce the venous pressure. So it improves deep venous return because it is going to provide graduated external pressure and it reduces venous pressure. This classification is very important. British classification of compression hosiery. Class 1, how much pressure is exerted? 14 to 17 mmHg. Class 2, pressure exerted 18 to 24, and class 3, it is 25 to 35. So can you tell me, class 1 to 3, which one is preferred for severe venous disease? Class 3. You have to remember, pressure 25 to 35. So this is preferred for severe venous disease. Class 3, when the pressure is, where the pressure is 25 to 35, it is preferred for severe venous disease. Preferred for severe venous disease. It's a question. So this is preferred for severe venous disease. Remember the name of classification? British classification of compression hosiery. Now see the methods of endothermal ablation. First is EVLA, endovenous laser ablation. So in this endovenous laser ablation, how much is the wavelength of laser energy? It is 1470 nanometer. Wavelength, it is 1470 nanometer. And how much is the energy required for durable closure? It is 60 to 80 joule per centimeter. Energy required, remember these values, 60 to 80 joule per centimeter. What are the types of lasers used? Forward firing as well as lateral firing. So types of laser used: forward firing as well as lateral firing. So laser used, forward firing as well as lateral firing. Clear? What are the disadvantages? Here you have to go for continuous pullback. So here continuous pullback is required. That's the disadvantage. Continuous pullback is required if we are going for endovenous laser ablation. So continuous pullback, it is required. That's the disadvantage. Now you can see how it's done. So in this image, you can notice that patient is having varicose vein, and here laser fiber is inserted into the vein, and after that the laser beam is turned on in the vein, and you can see what, that the vein closes at the laser fiber is withdrawn. So when the lumen is getting collapsed, what will happen ultimately? Ultimately you can notice that the vein is going to convert into a cord-like structure. So vein closes as fiber is withdrawn, and ultimately the vein is going to collapse. So ultimately vein converts into cord-like structure. What is the good thing? It's a daycare surgery. Means you admit the patient in the morning and by evening you discharge the patient. So endovenous laser ablation. Next is radio frequency ablation. Here we are using electromagnetic current to create the thermal energy. How much temperature is used? Remember guys, this is very important. 120 degrees centigrade. And duration of treatment cycle, how to remember? Temperature 120, duration 20. Temperature 120, duration 20. So duration of treatment cycle, that is 20 seconds. 20 seconds. What's the advantage of radio frequency ablation over endovenous laser ablation? Here, shorter learning curve is there and continuous pullback is not required. So advantage, first, shorter learning curve. There is shorter learning curve, clear, and continuous pullback is not required here. Continuous pullback. So continuous pullback, that's not required. Pullback. So continuous pullback, it's not required. Not required. Right? So that is radio frequency ablation. How we do it? Just have a look. This is the varicose vein, and here catheter is inserted into the vein. After that, electrodes are deployed, and you can see the radio frequency energy is initiated, and you can notice the same effect. What will happen? The vein is going to close as the catheter is withdrawn. So ultimately what will happen? The vein is going to collapse and it is going to convert into a cord-like structure. Again, it's a part of daycare surgery. Next is sclerotherapy or foam sclerotherapy. First tell me, for which veins we are using foam sclerotherapy? Remember the diameter. Whenever the diameter of vein is less than 3 mm, it means it is not fitting into the definition of varicose vein. So sclerotherapy, what you do? You inject the sclerosing agent directly into the vein. What is the most commonly used agent? Here we are using sodium tetradecyl sulfate. So it is sodium. We are using sodium tetradecyl sulfate. Tetradecyl decyl sulfate. So agent used, that is sodium tetradecyl sulfate. Clear? What is the most widely used method for foam sclerotherapy? That is Tessari method. And you can see the image. In Tessari method, you can see this image. We are going to take these two syringes. Can you see this? These two syringes, here there is foam and here there is air. So what we have to create a mixture. So a ratio mixture of sclerosant and air is created, and it should be 1:3 or 1:4. Remember, ratio mixture of sclerosant and air created by this Tessari method, 1:3, or it should be 1:4. And how much amount of foam is injected at a time? It is 1 to 2 ml only. And the maximum volume of foam which is injected in a single session, that is 10 to 12 ml. Clear? So how it works? Obviously, if you inject the sclerosing agent and you just press the vein, there is sclerosis, and after that what will happen? Fibrosis. So this is done for the smaller veins diameter less than 3 mm. Nowadays we can use endovenous glue, means directly you can inject the glue inside the vein. Which glue? You have to remember the name. This is cyanoacrylate glue. Name of glue? It is cyanoacrylate. So what's the name of this glue? This is cyanoacrylate glue. The glue is cyanoacrylate. And what we have to do? First inject the glue, and after injection the vein is compressed so that the lumen is sealed. So sealing the lumen closed. So glue, you have to remember, it is cyanoacrylate glue. Now see the traditional operation which is known as Trendelenburg operation. What we do here, in this case we perform flush ligation at saphenofemoral junction and individual ligation of tributaries, and after that stripping of the vein. So what we do first, you can see the incision. After incision, you can see we are going to identify this saphenofemoral junction where exactly 4 cm below and lateral to pubic tubercle we give the incision. This junction is identified. After that, we have to identify the tributaries. You can see the tributaries, these are tributaries. Clear? So what you have to do? Individual ligation of tributaries. So you can see the tributaries. There is superficial inferior epigastric vein. There is superficial external pudendal, deep external pudendal, and superficial circumflex iliac vein. First, individually ligate all these tributaries. So you can see individual ligation of all these tributaries done. After that, flush ligation is done at saphenofemoral junction. You can see flush means just at the junction. Yes, so we are going to ligate this long saphenous vein just at the junction from femoral vein. It is flush ligation. So you can see here flush ligation is done, and after that you have to strip the vein. So you can notice that this vein is stripped, and the stripping you have to be careful that it should not be done below knee joint, up to the knee joint, because below knee joint what happens? It travels closely with saphenous nerve that might be injured. So stripping of long saphenous vein just below the knee joint is done. Clear? So the vein is removed and we are going to close the incision. This is Trendelenburg operation. Sometimes in exam, they ask you what are the tributaries ligated. So laterally, we are going to ligate superficial inferior epigastric vein and superficial circumflex iliac vein. Medially, superficial external pudendal and deep external pudendal. Distally, anterior accessory of great saphenous vein or long saphenous vein and posterior-medial thigh vein, these are ligated. And after that, flush ligation is done where exactly? At saphenofemoral junction, right? Otherwise, if you're not going for flush ligation, if you're going to leave the stump, what will happen? In standing position, there is a painless swelling known as saphina varix. So it can cause saphina varix, which we discussed previously. And after flush ligation, stripping is done just below the knee joint. Whenever you are going to perform stripping beyond the knee joint, what happens? Yes, or below the knee joint, there is most commonly injured nerve. During stripping of long saphenous vein, there is injury of saphenous nerve. Clear? So there is injury of saphenous nerve, and whenever there is stripping of short saphenous vein, there is injury of sural nerve. Sural nerve. So you can see the image how the vein stripping leads to injury. In this image, you can notice that. But if stripping is done beyond knee joint, you can see this is the point of contact or risk point. So here, this saphenous nerve is injured. And what is the problem with sural nerve? Yes, you can see that short saphenous vein, it travels closely along its whole course with sural nerve. So whenever you're going to perform the stripping of short saphenous vein, there is injury of sural nerve. So these are the questions which are asked frequently. There is one treatment option which is asked, and only short form is asked, not the full form. SIPS, it is subfacial endoscopic perforator surgery. First question, we are going to use endoscope Why? This surgery is used for perforator. What kind of perforator? Incompetent perforator. So first question, the surgery is used for incompetent perforator. It is used for incompetent perforator. See, everything is written in this term SIPS. It is used for incompetent perforator. Second, with the help of endoscope, we are going to place vascular clip where subfacial means below the deep fascia. So vascular clip is applied where? Over incompetent perforator. Subfacial where? Below deep fascia. Below deep fascia. Below deep fascia. With the help of endoscope. Endoscopic with the help of endoscope. So SEPS, subfacial, below deep fascia, with the help of endoscope, perforators are ligated. How we are going to apply the vascular clip? In this image, you can notice that the vascular clip is applied in this SEPS. So this is incompetent perforator, and over the incompetent perforator, you can notice that these are the clips which are being applied. Clear? So this is SEPS. There is another question which is asked, that is Cocket and dots operation. So here we go for subfacial ligation. Subfacial ligation of incompetent perforators, that is known as Cocket and dots operation. Next treatment option is TIP using Trivex system. First, tell me the full form of TIP. TIP is trans-illuminated powered phlebectomy. And the Trivex system, it is using illuminator and vein resector. So what you do first, here you can notice that in this image you can notice that first we give the incision. You can notice the varicose vein. After that, we have to give the incision. Incision is being given, and then irrigated trans-illuminator. It is passed deep to the varicosity. You can see here. So irrigated, you can see irrigated trans-illuminator. It is passed deep to the varicosity, making it visible. So you can see this visible varicosity. And after that, another incision is given. So powered, this is powered suction resector. It is introduced through a separate incision. And after activation of this system, what will happen? This vein is sucked under the direct vision, and after that it is morcellated and removed by suction. Clear? So you can see here, this powered suction resector is introduced through a separate skin incision, and on activation of this system, what happens? This resector, it is going to suck the vein inside, and then the vein is morcellated and removed by suction. So this is TIP using Trivex system. Now, see the complications of varicose vein surgery. Guys, first tell me what is the most common complication? Remember, it's wound infection. So what is the most common complication? That's the wound infection. Clear? It's the wound infection. What is the most serious complication? Yes, nerve injury. Nerve injury. After surgery, we discussed that in some cases there can be recurrence, and especially when you are going for stripping, what happens? You have seen in the OTs that, or in the post-operative period, that patients are going to develop hematoma or ecchymosis. And most important, sensory nerve injury. During stripping of long saphenous vein beyond knee joint, what happens? There is injury of saphenous nerve. Can you tell me the percentage? Yes, percentage, or how much is the incidence? In 7% cases. Saphenous nerve injury in 7%. Since short saphenous vein, it travels together with sural nerve along its whole course. That's why during stripping of short saphenous vein, the injury of sural nerve is very high. How much? 20%. So during stripping of short saphenous vein, there is injury of sural nerve, and in what percentage? 20%. 20% followed by common peroneal nerve in 4% cases. Followed by common peroneal nerve. Clear? So it's common peroneal nerve in 4% cases. Common peroneal nerve in 4% cases. Clear? So these were the complications. Remember, most common complication, wound infection, and most serious, it's nerve injury. Now see the varicose ulcer or venous ulcer. Varicose ulcer or venous ulcers, these are responsible for 60 to 70% of ulcers in the lower leg. And what is the most common site? We discussed Gator's area. And we discussed that what is this Gator's area? Gator's area, it is located just above medial malleolus. So location, it is located just above medial malleolus. See, there are certain theories for the formation of ulcer. Previously, it was said that is the fibrin cuff theory or WBC migration theory which is responsible. But nowadays, these theories are not acceptable. We already discussed that it's the chronic ambulatory venous hypertension which is responsible for most of the complications. So this is most accepted theory. Clear? So it's the chronic ambulatory venous hypertension, that's the most accepted theory. So you can notice in the patients who are having varicose vein, first you can see this kind of hemosiderosis. hyperpigmentation. You can see the lower limb, typically how it looks like inverted champagne bottle appearance. So what's the name of this appearance? You can see guys, inverted champagne bottle appearance. Next, how to differentiate arterial ulcers from venous ulcer? First, see the typical location, Gator's area just above medial malleolus. Can you see brownish discoloration, hemosiderosis, sloping edges, and you can see the granulation tissue. So venous ulcer, sloping edges, pink granulation tissue, and hyperpigmentation of skin, hemosiderosis. Now can you see this one? Arterial ulcer, you can notice that here it is punched out. Arterial ulcers are extremely painful and there will be signs of ischemia like loss of hair, thin shiny skin, brittle nails. Clear? So it is having punched out edges. So you can see punched out ulcer. This is arterial ulcer. What is the name of regime used for management of varicose ulcer? It is Bisgard's regime. And you can see there are 4 E's of Bisgard's regime. Guys, you have to remember the name and 4 E's. Clear? So Bisgard's regime, there are 4 E's. First, education of patient. What is the cause and how it can be managed? Elevation of the limb. So we ask the patient that whenever you're sleeping in the night, go for the limb elevation. During time of rest, go for limb elevation. Use elastic compression stockings. And which grade? According to British classification? Yes, grade 3. Pressure was how much? 25 to 35. We can use dressing. What kind of dressing is used? Here we are using 4-layer compression bandage. So here we are using 4 layers. 4 layers compression bandage is used. So we are using 4 layers compression bandage. Clear? 4 layers compression bandage, right? There is superficial venous ablation or surgery. This superficial venous ablation or surgery, it is going to accelerate healing and going to reduce the recurrence. So it is going to accelerate the healing. So it accelerates the healing, and reduce recurrence. So it accelerates the healing and reduce the recurrence. There is a drug which we are using, yes, and this is pentoxifylline. What's the name of the drug? It is pentoxifylline. It increases microvascular perfusion, and since it is going to increase the microvascular perfusion, it is going to augment the ulcer healing. So it increases microvascular perfusion. Important point, pentoxifylline. Latest update, increases microvascular perfusion, and that's why it is going to augment ulcer healing. Right? There is another latest update. We can use horse chestnut seed extract. This horse chestnut seed extract, this is safe and efficacious treatment for chronic venous hypertension. So it is safe and efficacious treatment. Safe and efficacious treatment option for chronic venous hypertension. So this is how we manage the patients who are having venous ulcer or varicose ulcer. Now see this condition, this is known as iliac vein compression syndrome. So first, the term is self-explanatory. There is compression of common iliac vein. On which side? Left. So what happens? There is compression of common iliac vein, left common iliac vein. Why? Because of, you can see, this overriding right common iliac artery. What are the other names you have to remember? May-Thurner syndrome, also known as Cocket syndrome, also known as iliocaval syndrome. So first, iliac vein compression syndrome. So there is compression of left common iliac vein. First question, you can see left common iliac vein, and it is compressed by overriding right common iliac artery. By overriding right common iliac artery. Now see how it's going to happen. Now in this image you can notice that this is left common iliac vein and this is right common iliac artery. So you can see left common iliac vein, right common iliac artery. So this is overriding, you can notice that this is the overriding right common iliac artery which is going to compress this left common iliac vein. So what will happen ultimately, you can see here, yes, this left common iliac vein, it is compressed by overriding right common iliac artery. If a vein is compressed, obviously there is increased risk of DVT. So because of compression of this vein, what will happen? It can cause left iliofemoral thrombosis. So it can cause left iliofemoral vein thrombosis. Iliofemoral vein thrombosis. Iliofemoral vein thrombosis. So guys, this you have to remember. Left Iliofemoral vein thrombosis. Name is self-explanatory. Iliac vein compression syndrome, compression of left common iliac vein by overriding right common iliac artery. There are certain syndromes associated with AV malformations. First, see Klippel-Trenaunay syndrome. See this image first. You can notice that this patient is having this kind of hyperpigmentation. This is cutaneous hemangioma. And second thing, you can notice that patient is having varicosity. What is the basic problem here? These patients are having congenital AV fistula. And if in any limb there is AV fistula, you know that what happens? There is hypertrophy of involved extremities. That is known as local gigantism. So because of congenital AV fistula, there is hypertrophy of involved extremities and it leads to local gigantism. It leads to local gigantism. Clear? Next, you saw here, patient is having cutaneous hemangioma, patient is having varicosity because of AV fistula, and typically here there is absence of deep venous system. So guys, one easy question. If there is absence of deep venous system, stripping should be done or not? Since this patient is having varicosity, stripping should be done or not? No. Stripping is contraindicated. Why? Since there is absence of deep venous system, that's why stripping is contraindicated. Stripping. Yes, it is contraindicated because superficial system is the only channel for venous drainage. If you're going to strip it out, what will happen? Patient will be having severe complications. So these patients are managed conservatively. How? By elastic compression stockings. So how we are going to manage these patients conservatively? By elastic compression stockings. And guys, tell me the name. Remember the name, Klippel-Trenaunay syndrome. How to manage? These patients are managed conservatively by elastic compression stockings. There is another syndrome which is associated with AV malformation, that is Casa-Back-Merritt syndrome. What is the problem here? These patients are having congenital AV malformations, and because of these AV malformation, these patients are having pulsatile varicose vein. So sometimes questions are asked in this manner that pulsatile varicose veins are seen in Casa-Back-Merritt syndrome. So it leads to pulsatile, clear? Pulsatile varicose vein. It leads to pulsatile varicose vein. Here you can see the lesion. You can see the lesion here, right? These patients, because of congenital AV malformation, there is microangiopathic hemolytic anemia. And if there is hemolytic anemia, in these patients, there is consumptive coagulopathy, platelet trapping. And if there is platelet trapping, obviously what will happen? The platelet count is going to reduce. It means it leads to thrombocytopenia. Clear? So it leads to thrombocytopenia. So platelet trapping, it leads to thrombocytopenia. In this case, what is the problem? AV malformation. How you can manage it? Embolization. Second, the patient is having varicosity. How you can manage it? External compression bandage. So conservative management, what we can go for? External compression bandage. Because patient is having pulsatile varicose vein, so we can go for external compression bandage. An important point, patient is having AV malformation, so we can go for what? Embolization. So since AV malformations are there, we can go for embolization. Clear? What is done? What can be done? Embolization. Now during internship, you tell me what is the most important work you do? Yes, it's cannula. So in the beginning, you learn how to insert the cannula, and after some point of time, you are just going to check the vein. If you just press the vein and just look at the vein, and you understand that whether you are going to insert the cannula or not. What happens if you insert cannula every third day, fourth day? The nurse is going to tell you that, sir, iska cannula kharab ho gaya, iska yahan block ho gaya, you have to insert it again. So what is the problem? Yes, superficial thrombophlebitis, and you have noticed that redness. You have noticed that patient is having pain, and you are going to put the cannula in other hand. So can you tell me what is the most common cause of superficial thrombophlebitis? Yes, it is IV infusion. Guys, the most common cause, that is IV infusion. It can occur because of trauma. It can occur in patients of Burgess disease also. We discussed that. In Burgess disease, what is the triad of Burgess? Mnemonic was RIM. RIM means Raynaud's phenomena, I means intermittent claudication, and M, that was migratory superficial thrombophlebitis. After that, there are certain malignancies also which can cause superficial thrombophlebitis. Yes, which malignancy? Guys, it is carcinoma pancreas, most commonly associated with superficial thrombophlebitis. Now see the malignancies associated with migratory superficial thrombophlebitis. First, carcinoma pancreas, most commonly associated. Ovarian cancer, carcinoma lung, lymphomas, carcinoma prostate, and GI malignancies. So how to remember, guys? Mnemonic is post LPG. It is post LPG. So that is post LPG. P means pancreas, O means ovary, L means lungs, lymphoma, P means prostate, G means GI malignancies. So these are the malignancies associated with migratory superficial thrombophlebitis, and the most common malignancy, it is carcinoma pancreas. You know, if there is migratory superficial thrombophlebitis associated with malignancy, what's the name of this syndrome? This is known as Troisiu syndrome. So you can see here, this patient is having migratory superficial thrombophlebitis associated with malignancy. What's the name? Troisiu syndrome. So name. So you know, migratory superficial thrombophlebitis. What's the name? This is Troisius. So this is Troisiu syndrome. Troisiu syndrome. Next, if the patient is having carpopedal spasm in hypocalcemia, you can see here, after cuff inflation, what happens? There is carpopedal spasm. So this carpopedal spasm, this is known as Troisiu sign. So this is known as what? Troisiu sign. And similar term is there. Some patients are having left supraclavicular lymphadenopathy. In this image, you can notice the patient is having this left supraclavicular lymphadenopathy, and this is known as what? Troisier sign. So palpable left supraclavicular lymphadenopathy. What's the name? This is Troisier's. So what's the name? This is Troisier sign. So this is Troisier sign. Now, can you tell me there is risk of pulmonary embolism in superficial thrombophlebitis or not? We discussed no. Why? Because we discussed that if the vein diameter is very small, what happens? The thrombus is strongly adhered to the wall. That's why the risk of pulmonary embolism is almost nil in superficial thrombophlebitis. But in larger vein, if there is thrombosis, there is increased risk. You have seen multiple cases of thrombophlebitis. So if you feel the vein is just like a cord. So cord like it's tender, and you can see there is erythema, there is redness of the skin. So the patients who are having superficial thrombophlebitis, vein feels like cord like. So vein feels like cord on palpation. Obviously there is tenderness and there is erythematous skin around the vein. So what to do? Nothing. Majority of cases are going to resolve spontaneously. Just to control inflammation, we are going to give the NSAIDs. So for inflammation, we are giving NSAIDs. Next is axillary subclavian vein thrombosis. In short, it is known as ASVT. In short, it is known as ASVT. Clear? So here you can see here that in this case there is venous thrombosis of axillary vein, subclavian vein. So this is involving upper extremity. That's why it is also known as what? Upper extremity DVT. We discussed that if a patient is having lower extremity DVT, there is risk of pulmonary embolism. So in upper extremity DVT also there is risk of pulmonary embolism. Next, tell me which one is more common? DVT is more common in lower extremity or upper extremity? Obviously lower extremity. So this is upper extremity DVT. Obviously it's less common. It is less common in comparison to lower limb or lower extremity DVT, but it is associated with pulmonary embolism. In what percentage of cases? In up to 1/3. In up to 1/3 of cases, it is associated with pulmonary embolism. What are the types of ASVT? Primary and secondary. Whenever there is no well-defined cause, if the cause is not clear, it is primary. And whenever it is secondary to hypercoagulable state or some kind of indwelling catheter, it is secondary. So this primary ASVT, it is also known as venous thoracic outlet syndrome. TOS, that is venous thoracic outlet syndrome. It is also known as effort thrombosis, also known as Paget-Schroeder syndrome. Out of primary and secondary ASVT, tell me which one is more common. Secondary ASVT, this one is less common. Now, what is the problem here? In this case, you can see what's the problem. Why it is known as effort thrombosis? In this image, you can notice that this is subclavian vein. You can see the location. And this subclavian vein, it is between this clavicle head and what? First rib. So whenever a patient is doing this kind of repetitive motion, can you see? If patient is doing repetitive motion, what will happen? There is damage to subclavian vein between clavicular head and this first rib. So whenever damage occurs between clavicular head and first rib, what will happen? After that, you can see there is thrombosis, and whenever there is thrombosis, there is damage. You can notice that there is formation of circumferential perivenous scar, and because of this scar, what happens? Obviously the lumen is compromised, there is thrombosis. After that, what will happen? There is formation of collaterals. So thrombus formation followed by what? Collateral formation. So this is going to happen in ASVT. And you can see after if this, because vein is occluded, so obviously there is collection of deoxygenated blood, and what will happen? There is bluish discoloration, there is edema, there is pain. So I'm repeating, This is known as effort thrombosis. Why? Because there is damage of subclavian vein between clavicular head and first rib whenever there is some kind of repetitive motion. Now, secondary SVT, more common. It is secondary to hypercoagulable state and indwelling venous catheter. You might have seen that indwelling venous catheter, especially in the medicine or in the ICU, right? So, whenever there is venous thrombosis, obviously the signs and symptoms are similar to DVT. Investigation of choice is same and management is also similar like DVT. So just like lower limb DVT, these patients are having pain, there is swelling or edema, there is bluish discoloration because of collection of deoxygenated blood. There is collection of deoxygenated blood, clear? So it is similar. Investigation of choice, again it's same, we are going for duplex scan and management is also all same. We start anticoagulants and we go for catheter directed thrombolytic therapy. So this is how we manage the patients who are having ASVT, axillary subclavian vein thrombosis. So now guys, let's discuss the MCQs. First, you can see a 54 years old male who has been bedridden for past 6 weeks complains of severe cramping pain in left leg for the past 3 days. He is unable to move his leg due to pain. The calf muscles are warm and extremely tender, so there is calf pain, calf tenderness. D-dimer test, it is raised. Doppler ultrasound shows clots in deep veins, means the patient is having DVT, which is high risk factor for disease in the patient. We discussed that. What is low risk? Head and neck surgeries means neurosurgery, maxillofacial, cardiothoracic. Moderate risk, abdominal and pelvic, general surgery, urological surgery, gynecological surgery. High risk, orthopedic surgery involving pelvis and lower limb. So mobile patient obviously is not a risk. Trauma is a risk, but it's not the high risk, not the high risk factor. Surgery lasting for more than equal to 30 minutes, again it's a risk factor but not high risk. What? Major orthopedic surgery of lower limb, obviously it's a high risk. Correct answer is C. Now see this question. 43 years old male presents to hospital complaining of pain in right calf muscle. Patient also complains about swelling and redness. There is swelling and redness in affected area. Examination reveals the patient has calf pain with knee flexion and dorsiflexion of ankle. It means what happens? Homan sign is there. Yes. Calf compression against tibia also causes pain. Clear? So, Moses sign. Duplex ultrasound results are suggestive of DVT. Which of the following statement is true? So, patient is having DVT. See the facts. Most common site of DVT leading to pulmonary embolism. It's not soleal vein. It's thigh vein. This is thigh vein, which is also known as what? Femoropopliteal vein. So this is thigh vein, also known as femoropopliteal vein. So thigh, also known as femoropopliteal vein. Second, earliest sign of DVT, it's not calf pain, it's calf tenderness. So this is not the calf pain, this is calf tenderness. Yes, Homan sign is the resistance to the calf muscle to forcible dorsiflexion. This is correct. Filling defects, inflow, lack of compressibility indicate presence of an ulcer. No, it indicates presence of DVT, not the ulcer. So what is the correct answer here? Correct answer is C. Now see this question guys. 20 years old patient presents to hospital with complaints of varicose vein in left leg since birth. He also complains of dilatation increases while walking, standing decreases while sitting. On examination, it is seen that patient has cutaneous hemangioma. So varicosity is there. Second clue is cutaneous hemangioma. First clue, varicosity. Second is cutaneous hemangioma involving the face with enlarged toes. What you can see? Local gigantism. Color Doppler results show multiple varicosity all over the leg and lower thigh region. What is likely to be the diagnosis based on patient's condition? Clear cut, Klippel-Trenaunay syndrome. So guys, this is Klippel-Trenaunay syndrome. In Casa-Back-Merritt syndrome, what happens? Cutaneous hemangioma is not there. Pulsatile varicose veins are there. Microangiopathic hemolytic anemia, there is thrombocytopenia. So correct answer for this question is A, that is Klippel-Trenaunay syndrome. Next, 50 years old male presents with complaint of pain where? In the right foot with severe burning sensation. On examination, veins are dilated and tortuous. So patient is having varicose vein. Ulcer means varicose ulcer. There is serous discharge exactly on the medial malleolus. You can see it is located in the gatus area. Doppler scan revealed incompetent perforators. Now, according to CEAP classification, how would you classify the patient's disease? Patient is having ulcer, which is active. And guys, you know that if active ulcer is there, it is C6. Healed ulcer, C5. What is mnemonic? TV of pig lip corona. It was TV of pig lip corona. Clear? So T, this was 1, telangiectasia, V, varicose vein, 3, edema, pig, pigmentation, lip, 4A, pigmentation, 4B, lipodermatosclerosis, 4C, corona phlebectatica, 5, C5 was healed ulcer, C6, that was active ulcer. So correct answer is C6. So this is all about venous disorders.